Hi Tom, my name is Ali. I'm the duty consultant today. Thanks for coming. We'll have a chat with you about the blood gas interpretation, and we always have to correlate with the patient. Now, looking at the gas, he's got a pH of 7.6, so that's indicative of alkalemia. His pH is a 20, so he's hyperventilating, so that's mean he's got respiratory alkalosis. Looking at the bicarb is very low, so I calculate the NaN gap. He's got high NaN gap, as well as he's got high delta ratios more than 1. Excuse me. So that's indicative of he's got high NaN gap, metabolic acidosis, and respiratory alkalosis. So it's a mixed picture, or mixed acid-base disturbances. Given that the patient has got an overdose, excuse me, 3 hours ago, and also had a seizure. This is most likely it's a salicylate poisoning, but we have to keep the differential wide. Think about other toxicological causes like sodium channel blocker toxicity, TCA, toxic alcohol, ethanol, methanol, ethylene glycol, paraldehyde, INH, metformin. Also think about other causes like sepsis, other causes of lactic acidosis, and uremic renal failure as well. So looking at the patient is very unwell. He's got seizure, he's tachycardic, he's hyperventilating, and his blood pressure is low. The patient needs immediate resuscitation, and we'll talk about that. Now back to the gas. As we said, he's got a mixed picture of respiratory alkalosis and high NaN gap metabolic acidosis as a mixed picture. His electrolyte is potassium is 5.8, so that's a moderate hyperkalemia. Need an immediate ECG. Looking for ECG changes of widening QRS, flattening T wave, and hypertenting T wave. And if there is evidence of that, he needs immediate treatment of his potassium. Has a glucose 3, there is a hypoglycemia. Again, that's needed immediate treatment with 10% dextrose. The intention is just to keep the BSL more than 5. What do we do next? So the patient he's very unwell. He's already had a seizure. So given 3 hours post, it's most likely severe salicylate poisoning, and most likely he ingested more than 300 milligram per kilogram per his body weight, and he's at risk of having another seizure. We would like to do the risk assessment for the poison. We need to estimate the amount of ingestion, the time of the ingestion, if there's any co-ingestions, and then we start treatment with also decontamination. So he's going to need an immediate charcoal 50 gram, and this is supposed to be via nasogastric tube after we secure the airway, because there's a high risk of seizure, or could be aspiration due to alteration of conscious state, or maybe there is another co-ingestion. So the priority is to keep the airway secure by rapid sequence induction. Simultaneously, we have to fix the C, because he's tachycardic hypotension. We need immediate fluid resuscitation with normal saline 1 liter stat, aim of blood pressure of more than 100 and heart rate less than 100. Also, I would like to give him sodium bicarb to enhance elimination and urinary excretion of the salicylate. I would give him 100 millimole of sodium bicarb immediately, followed by 100 millimole in a liter of saline, give it at a rate of 250 mils an hour. Maintain the suppressive measure, maintain his normothermia, normal glycemia, and at the same time, when we ventilate this patient after we secure the airway with RSI, then we would like to keep him hyperventilating just to maintain the respiratory alkalosis. In terms of, are you following so far? Okay. Now, in terms of the rest of the treatment, we would like to, as we mentioned about the urinary alkalization, and maintain hydration, maintain urine output more than 2 mils per hour. Also would like to check the bloods again, looking for improvement of his gas, and just to tell us the progress of the treatment. And also we check the salicylate level. Now salicylate per se, it's not correlate with the severe toxicity. However, the level may guide us with the clinical picture of the patient about the indication of dialysis. So if we've got a salicylate level more than 7.7 millimole in acute poisoning, that's an indicator of dialysis. As well as if it is more than 4.4 millimole per liter, this is an indication of, in a chronic poisoning, this is an indication of dialysis. Now, other indication of dialysis as well is the urinary alkalization is not feasible. The patient in a severe acute renal failure, if the patient has got worsening acidosis or continued hemodynamic instability, that's an indication of dialysis. Now, after we stabilize the patient, we would like to talk about disposition. So this patient need ICU level care. We'll have to refer to the ICU for continuing support of his airway, breathing, circulation, as well as we will also talk to a toxicologist if we need a further advice in terms of the management, or if the patient is deteriorating more. Are you following at this point of time? Do you have any questions? Or after that, I'll just give you some resources. There's a very good text and website we can talk about. It's just give you a good approach about interpretation of blood gas, and also the college website in their modules. They've got a very good sort of lectures about acid-base interpretation. Thanks.